The urinary bladder is filled with anechoic urine, and side lobe artifact is common. Reducing gain in the area of the bladder helps to reduce or eliminate the artifact. Decreasing depth to help magnify the image will also reduce through enhancement artifact of more dorsal structures. When the bladder is empty or nearly empty, the muscular bladder wall contracts to become visibly thickened. Crystals, bladder stones, and even tumors can be hidden by the thickened bladder wall. It is best to refrain from making any judgments about an empty or nearly empty bladder. When moderately filled, the bladder wall will be a smooth, evenly thin line. When moderately filled, the bladder wall should not be greater than 2 millimeters thick. In dogs and cats, the normal bladder wall may appear to have two thin hyperechoic lines with a hypoechoic line in the middle. When overfilled, the bladder wall may appear as a single hyperechoic line. An overfilled bladder wall should be stretched thin and should be less than 2 millimeters thick. The ureteral papilla can often be seen during the examination of the bladder. It appears as a small, hyperechoic protrusion in the caudal third of the dorsal bladder wall, slightly to the right and left side of the midline. Sometimes pulsatile urine flow is seen coming from the ureteral papilla. When normal ureteral peristaltic contractions are occurring, urine flow from the papilla can be seen with and without color flow Doppler, as seen in this transverse view from a 13-year-old chow with a bladder tumor near the ureteral papilla. In this case, a weak grayish disturbance moves upward at the green arrow. When viewing the urinary bladder in a ventral midline transverse view, the descending colon is usually located to the patient's left side of the bladder, although it can also appear on the right side of the bladder. As the transducer slides caudally, the colon eventually moves dorsal to the bladder and urethra. When viewing the urinary bladder in a ventral midline sagittal plane, the transducer is fanned to the patient's left side. It is common for the descending colon to appear as though it is inside of the bladder. Many beginners mistake this appearance for a large stone in the bladder and may even send the patient to surgery to remove the stone. Always view the bladder in a sagittal and then a transverse plane. The transverse view will show that the colon is merely pressing into the bladder wall and not located inside of the bladder. With the transducer in a ventral midline sagittal position, slide the transducer caudally to find the trigon area of the bladder. Continue to slide slowly caudally while fanning slightly to the patient's right and then left to center the urethra on the ultrasound screen. With the transducer in a ventral midline transverse position, the caudal aorta and caudal vena cava are seen dorsal to the urinary bladder. As the transducer slides caudally, the aorta splits into 3 vessels. This is the aortic trifurcation and is a landmark for finding lymph nodes and blood clots. These vessels can be seen with or without color flow Doppler. Pulsations of the aorta are readily seen. The aorta presses against the caudal vena cava, causing it to appear to pulsate as well. Color flow Doppler shows direction of blood flow. Flow towards the transducer is shown as red. And flow away from the transducer is blue. The Nyquist limit, or flow velocity in centimeters per second, is adjustable. The Nyquist limit is located above and below the color flow icon. In a ventral transverse transducer position, it is necessary to fan slightly cranially so that aortic flow coming from the patient's heart toward the transducer will be red. Flow velocity in the aorta is higher than flow velocity in the caudal vena cava. The Nyquist limit must be lowered to show blue color, or flow away from the transducer in the caudal vena cava. When the Nyquist limit is lowered for the velocity in the caudal vena cava, aortic flow exceeds the Nyquist limit and causes flow in the aorta to wrap around from red to blue. Therefore, flow in the aorta is now red and blue. When using a ventral sagittal transducer position, it is necessary to angle slightly cranially so that blood flow in the aorta is moving toward the transducer and will be red. Because these vessels are side by side, it is usually necessary to fan slightly to the patient's right or left side to see the vessels one at a time. Blood flow in the caudal vena cava will be moving away from the transducer and will be blue. Near the trigon of the bladder, in a ventral sagittal view, the aorta divides into 3 vessels. This location is known as the aortic trifurcation. Blood clots, the medial iliac lymph nodes, and the hypogastric lymph nodes can be found in this location. The blood vessels and aortic trifurcation can also be viewed from a right or left lateral sagittal transducer position. The aortic trifurcation is a landmark for finding lymph nodes and blood clots. The urinary bladder and the major blood vessels dorsal to it are landmarks for finding the uterus in intact females and the uterine stump in spayed females. It is easiest to find the main body of the uterus in a ventral midline transverse transducer position. After finding the bladder, slide the transducer caudally toward the trigon. The uterus is usually a small, rounded, homogeneous tissue density dorsal to the bladder and ventral to the blood vessels. The transducer can be moved cranially or caudally to follow the uterus to the cervix or the horns of the uterus in an intact female. The uterus can also be seen in a ventral midline sagittal transducer position. In the sagittal or long axis view, the uterus will be a homogeneous tube. The transducer can be moved cranially or caudally to follow the uterus to the cervix and the horns of the uterus in an intact female. If the female is in estrus or has endometritis, the uterus becomes hypoechoic. and is easier to find, as seen in this transverse view.